Thank you, Judy, and thank you for inviting me to come today. And I enjoy talking about the kind of work we do, and I'm interested to hear your feedback and questions when we're done. As Judy said, Steve Evans, a professor at Ohio University. I got there in 2009 and have been working on continuing my research on school-based mental health services and so classroom and mental health interventions for children and adolescents with emotional behavior problems. I tend to focus on middle school and high school kids, so adolescents. And what's nice is the co-director of the center with me focuses on elementary school, so we have enough nice dovetailing of expertise, and then we have a variety of faculty from our College of Education, from the med school, and from psychology who also work with us in the center. So we enjoy, as I assume many of you do, trying to make a difference for many students with emotional behavior problems that get in their way of succeeding in school. So make sure I'm doing this correctly. Okay, so I put this up here realizing I'm probably preaching to the choir when I go over this, but I really think schools are the front lines for mental health care in our society, whether we like that or not. Then there are a lot of reasons for that. It's most children and adolescents never receive care. Most who have emotional behavior problems never receive care, and of those who do, they tend, the modal number of sessions I think they attend is 1 at outpatient clinics. So the opportunity to even get benefit from appropriate care is often not accessible adequately for many of these kids in community clinics and centers. One of the most common things that school mental health professionals, school psychologists, school counselors, school social workers, etc., often say is they refer a lot of kids and very few, if any of them, actually go and get anything that is substantial. The unfortunate thing too about clinicians and working in the community at various clinics is they tend to not be familiar with evidence-based practices. So the likelihood of going and getting something that has been developed and shown to be effective is also slim. So not only don't the kids and their families go, but even if they do, they're unlikely to get the things that we know are most effective. And as you're probably aware, there are many obstacles to this. There's cost, time, getting the parents invested to keep going and to take you. One of the most common obstacles to care when you're working with these kids is the belief by the kid and often the parents that it will not be helpful. And unfortunately, if you look at a survey of what mental health clinicians and clinics often do, it's not likely to be helpful. And you know, we often think about psychosocial treatments, many people do, as not having negative side effects like medication it often does, but it does have negative side effects. If you go and you don't get help that's beneficial, the negative side effect is you don't go back to the mental health community anywhere, right? Because the parents and kids tend to clump us all together and say, I tried mental health counseling and it doesn't work, so I'm not going back. To me, that's a pretty bad side effect, and one that in this area of psychosocial care we don't take much responsibility for, but I think it's important. Similarly, clinic-based care has logistical disadvantages compared to school-based care. For example, I mean, again, if you've worked in schools with these kids, you know that if all you had was 50 minutes to talk to an adolescent and or their parent about how they're doing, what they're doing well, what they're doing poorly, and you had no corroborating information from anyone else, you're probably not going to get very much of the story, right? And you're not even going to know what's true and what's not true. It's like the line about working with adolescents. How can you tell when an adolescent is lying? He opens his mouth. So it's hard to, you know, at a clinic, you're not going to know the truth. At schools, you have lots of advantages. You can talk to the teachers easily. You can observe, and especially the less structured settings like the cafeteria, even just the hallways and various classrooms, you can gain so much more information about how that child is functioning interpersonally, academically, responsibility, self-care, etc., discipline, in a much shorter time and with much greater breadth of knowledge than you ever could when working in a clinic. Similarly, you're not going to know why things you recommend may not be working. First of all, you're working on this slim skeleton of knowledge if you're in a clinic about what's really going on, and then you may make some recommendations to do certain things, and you find out they're not working, but you can't really know why as nearly as well as if you're in that school, and you can watch where you, in the cafeteria where you told the child to do something or the child was going to try something, you can see why it's working where it's not. So for a lot of these reasons, I'm convinced this isn't just the front lines by default. It's the front lines because it's where we have a bigger opportunity to make an impact on the mental health and the functioning of kids with, all kids really, but kids with emotional behavior problems. And that's an important population to target, obviously, because some of you have seen, I imagine, the studies Mary Wagner and others have done looking at outcomes of these kids, which are pretty poor in terms of long-term, in terms of employment and just being involved in marital relationships, having an income, supporting yourself. Many of them live in the basements of their parents after they leave high school, which may or may not be due to graduation. So it's a tough group and one that I think we really need to work hard to make a difference for. So I think there are actually 3 things that we need to do. If you're working in a school and you're a school mental health professional, and a lot of our work is in, like I said, middle schools and high schools, there are 3 things that are most important in terms of making a difference with these kids. And one of them is the relationship. And I'm going to talk a little bit more about that. In our studies, we train our clinicians around all the procedures and the details and the assessment points and all of that, how to document things. And then we end that before they go into the schools, and we say, before you think about any of this stuff, let's spend some time talking about a relationship and how to communicate effectively, how to have a relationship with a 14-year-old who doesn't believe he has any problems. It's all everybody else has the problems because they're not fair to him. And the second piece is then the interventions that you do. If you are if you're good at developing a relationship and you decide you're going to do insight-oriented counseling to address the ADHD-related impairment and substance abuse problems of a 15-year-old, you can have a wonderful relationship, but that intervention isn't likely to make a dent in that student. He or she may like you, they may like coming, but in terms of addressing that related impairment, it's unlikely. So you need both those things. And finally, the third thing I'm going to talk about is self-care. And that's an important piece. I think when you don't take care of yourself adequately, your ability to take care of either of these first 2 is diminished. And I'll show you, there's a little metaphor I use when I talk about this. If you think about yourself as an island, and you think about the student as another island, note his island is rockier. The first thing you need to do in order to make a difference for that kid is build a relationship, right? And in this, I refer to that as the bridge. If you don't have a bridge, nothing can effectively get across between you and that student. If you don't have the relationship, nothing can effectively get across between you and that student. And this, so the interventions then are the things that go across the bridge. So this works a lot of ways. You can see that if you have a nice bridge, you can get a lot of things across efficiently and effectively. However, it's also just extending this even further, you also have to have some boundaries. You can't always have the bridge open. Calling you at 10:30 at night is not a good aspect to the relationship, of course, you have as a school mental health professional. If you're so busy focusing on interventions and you don't maintain your relationship, the bridge fails and things don't get across anymore, and you don't get across to make a difference. And finally, if you try to do too many things at once, your relationship will be compromised, you'll get a back traffic jam and nothing ends up getting across. So, and the third necessary ingredient I talked about at the beginning was self-care. So if your island's on fire or you're not taking care of yourself very well, then the relationship and the bridge is compromised and you won't be able to get things across as well. So this is kind of the framework I use to approach all the research that I do. And I'm going to show you a little bit of research on relationships, but mostly on interventions, because intervention development is the priority of my focus. So the Challenging Horizons program, which I'll tell you about in a little bit, we just completed a large randomized clinical trial a couple of years ago, and we looked at 5 outcome measures, and we wanted to find characteristics of the kids or the process of what we did working with the kids that predicted good outcomes. Okay, so I think the 5 on here. No, but it had to do, oh, they're listed here. So there were 5 outcomes pertaining to academic functioning. And then all these variables here are things we used to see if they predicted good outcomes. So were they also using medication when we treated them? And is that, because that possibly could enhance the response to the psychosocial interventions, right? We looked at relationships in terms of the counselor's ratings of their relationship with the student and vice versa, the student's ratings of the relationship with the counselor. We looked at dose. This was a year-long, an academic year-long treatment study. So some kids attended more than other kids. So the more they attended our Challenging Horizons program, was that associated with better outcomes? Some studies have shown that oppositional defiant behavior reduces response to intervention. So we wanted to look and see if the more oppositional defiant behavior they had, the less likely they were to be a good responder. We looked at the home situation with measures of parent-adolescent conflict and parenting stress. Symptoms of anxiety actually have been shown with kids with disruptive behavior to predict better response to treatment. And that, if you think about it, that makes a little sense, because it'd be nice to get, and not to a pathological level maybe, but part of their problem is apathy about a lot of what other parents are concerned about. And finally, was there a gender difference? So think about looking at these, which of these, you don't have to tell me, but just pick in your mind 1 or 2 of these that you think are most likely to be associated with good outcomes in our treatment program. And I'll show you, hopefully you didn't pick either of those. Neither counselor ratings of the relationship with the student or oppositional defiant behavior that didn't predict good response on any of the 5 outcome measures. That's what the 0 is there for. That's how many outcome measures did those predict good response. And then we had some mixed results. We had medication use on 1 of the 5 predicted a better response. Symptoms of anxiety, same thing. Male and female was mixed on some measures. Female was predicted better success on some male. It was confusing and not real interpretable finding. But the 3 that made a real difference were student ratings of the relationship with the counselor, predicted 4 out of 5, dose 2 out of 5, and parent-adolescent conflict 3 out of 5. Those were the things that mattered. So we were interested in looking at what is it that about the relationship, about what kids see in the relationship with their counselors that makes them think they have a good relationship. So what we did is we used the Working Alliance inventory, which was the measure we used. We kind of broke it down to see if there were some messages we could pull out of it that would say, this is what's important for kids to think you have a good relationship. So these are all the items on the Working Alliance inventory, and you can see, I just highlighted in red some of the key phrases. But if you boil that down even a little further, what you see is that students must believe that we together to achieve them, and the counselor likes me, appreciates me, and respects me. And in essence, that's what they were rating, and that's what the kids were saying was happening in situations where they were most likely to achieve well. Interestingly, counselors' ratings, as you saw, had no effect. And I think part of that is somewhat related just to kind of a positive illusory bias amongst counselors. Yeah, I'm doing great. Everybody likes me. The kids should like me. So we had a little bit of a ceiling effect around counselor ratings of their relationship with kids, where we had much more variability around students' ratings of relationship with counselors. So what I'm going to focus on more is interventions or the traffic on the bridge. And I want to start by just presenting a framework of how I go about thinking about interventions and how things we need to do to develop them. And then how do we decide which ones to use first? And so prior to doing that, I'll share a few definitions of intervention-related terms to make sure we're on the same page, and then talk about the model of service delivery that we're using to frame and determine a sequence of our interventions. So these are two terms in schools that are often intertwined and used synonymously, even though they aren't synonyms. Interventions are strategies to develop or improve knowledge, skills, behaviors, cognitions, or emotions. And this is, from my perspective, the definition in the field of accommodations that was published by a renowned faculty member here at Rutgers. A strategy that holds the student to the same standard as their peers, but it provides a differential boost, and I'm going to show you a little more what that means in a minute. And it mediates the impact of the disability on access to the curriculum. So when you think of things that right now that are people often call accommodations, the most common ones probably given to kids with any disability, but certainly kids with ADHD or emotional behavior problems, is extended time. Unfortunately, extended time doesn't meet the definition of accommodation or intervention. It's essentially just reducing the expectations for the student and then give anybody more time and they can do more work, right? So it isn't really a differential boost, it's just giving them more time. And actually kids with ADHD are even less productive in the extended time than kids without ADHD are. So it's not so widely used. I don't believe it's so widely used because of its value. It's so widely used because it's cheapest. It's easiest thing to do. You don't have to try to make a difference. You just have to lower your expectation and allow more time, which is unfortunate, but we'll show you some more about that. Here's some terms pertaining to interventions. Cognitive therapy you've probably heard of, and as it pertained to ADHD, back if you were, depending how old you are, you may remember that in the 90s, there was a book that came out by Braswell and Bloomquist that's CBT, or cognitive behavioral therapy with kids with ADHD, and led to studies, and nothing turned out to be very fruitful among that. Teaching kids how to stop, think, and act, that kind of stuff, was a failed approach, really, unfortunately, to working with kids with ADHD. But if you think about it, and if you know kids with ADHD, children or adolescents, it kind of makes sense because, as you know, and as best practice for anxiety and depression, cognitive therapy is excellent for people with anxiety and depression. It's one of the most evidence-supported interventions there are. But what's one way to characterize the problems of individuals with anxiety and worry is they think too much, right? They worry, they obsess about bad things or how bad things are. And if you can interrupt or change that thought process, you can make a difference in how they feel. The opposite is true with kids with ADHD, right? They don't think enough. And if nothing's going on up there, what are you changing? You know, they can't get them to stop, think, and act just by practice and rehearsal to do that. It kind of made sense of why this is differentially effective depending on the problems of the kids. Behavior management, that is a set of interventions that are often used for kids with, especially elementary school age kids. And it comes down to manipulating the contingencies in the environment in which the target behavior is expected. So the two most common behavior management approaches are probably parent training, where we train parents to manipulate the contingencies in their home to increase the likelihood of appropriate behavior, and teacher or classroom management training, where essentially we do the same thing with teachers, right? We teach them to do a daily report card or use token systems or points or things like that in their classrooms in order to help manage the behavior of the kids. There's limited evidence that it generalizes beyond the setting. So if you think of secondary schools, you could have, if you've seen students with any kind of emotional behavior problems, they sometimes can go to classes and the teacher can say, you know, people told me he had problems, but he's great. I mean, I don't have any trouble with him at all. He goes to his next class and the teacher's like beside herself because he's Hellraiser in the class and they can't manage him. So the odds are this probably has more to do with the teachers than the kids in terms of their classroom management, in terms of their relationship, the bridges they can build with the kids, right? So you can get incredible variability, and just because one teacher's good at it won't help the other teachers typically in terms of behavior management kinds of interventions. There's a third kind that we focus on in our work with adolescents, training interventions, and that's where we instruct and train skills that were not previously exhibited. So, for example, we train students to do organization interventions. And what we do is reps and practice, and that's really what training interventions are all about, is reps and practice. But it doesn't have to be in the setting where the behavior is intended or desired. It can be in any setting. And you get them to do something over and over and over until it becomes routine. But over and over doesn't mean 3 or 4 times. It means dozens of times, and I'll show you some data on that in a little bit. If you think of, I use a basketball example sometimes, which given March Madness, it may be appropriate. When basketball players go to the gym and practice their shot over and over and over hundreds of times, that's training. That's a training intervention. When they go on the court and the refs call fouls, that's behavior management. Right? So that's the distinction there. I note at the bottom that many interventions involve a combination of those things. But I also added this definition slide to many of my talks because a colleague once told me that, well, all of us as clinicians try to target how they feel, how they think, and what they do, so we're all doing cognitive behavior therapy, right? I was like, I didn't say this. Well, and I'm not going to say what I really thought even now, but it's, of course not. That's ridiculous. If that was the definition of cognitive behavior therapy, then medication would be cognitive behavior therapy, right? Because it influences what you think and how you act and what you do. Cognitive behavior therapy is much more specific than that and different than training interventions. So in coming up with a model of how we decide what services, we went through a series of steps, and you can see I listed some people at the bottom who it was really the 5 of us who talked and worked through and developed this model together and published in a few book chapters and referred to now. George DePaul and Tom Power, Julie Owens, Jen Maftone, and myself. And we came up with what's the guiding principle. And our guiding principle was prioritize services that enhance the skills of students to independently meet age-appropriate expectations for academics, interpersonal, and vocational function. The key phrases I underlined. So it enhances the skills and it meets age-appropriate expectations, to independently meet age-appropriate expectations. And here's what we came up with. We call it the life course model. And it's a set of 4 layers. Tiers had already been taken, so we had to go with layers, that give you an idea of how to sequentially prioritize different kinds of intervention. And we'll talk through that in a minute. Cutting through all these are basic principles of care for service delivery, tending to cultural context and progress monitoring and all those things. I'm not going to talk as much about this because you're probably familiar with that, and everybody would nod their head when I read that part. The more controversial part, and I think more interesting part, is the definition of the layer. Layer 1 is simply foundational. So if a child gets referred to a student team at school for classroom problems, one of the first things you should probably do is assess the classroom, because there are some classrooms where a problematic child means all of the kids because the teacher's so poor at classroom management. And if that's the case, no matter what you do intervention-wise outside of that, you're going to have a hard time making a difference for that child if it's a chaotic classroom. Similarly, it could be a chaotic home or chaotic family. There could be some contextual things that are in the environment where the presenting problems are occurring that you need to address first. And if it's unreasonable or out of control, or you can't make a difference till those things are fixed, then that has to be your first target. Or you have to think about, how can I help this child in spite of the teacher, or in spite of the parent, or in spite of the community in which he or she lives. So that we put as the first layer. And it's, for some students, you go by that quickly because he's in a decent classroom, and everything, the context seems to be fine. He could be well behaved fairly reasonably. We put psychosocial interventions next, which includes cognitive therapy, behavior management, training interventions, because when those are implemented and those are responded to adequately and successfully, then the child can meet that goal that we said guided all our service delivery, which is improves competencies or skills so they can independently meet age-appropriate expectations, right? Because the intervention can end and then they can continue to do these things and they'll be independent of any service and meeting age-appropriate expectations. We put medication next because medication can do that very similarly in the sense that for some kids, at least talking about kids with ADHD, but this does apply beyond that, getting on stimulants can make the difference between them being able to stay in a gen ed classroom or not. There are some kids for whom all the psychosocial interventions in the world done perfectly with great fidelity probably isn't enough. And for those kids, medication can be important. However, we put medication after psychosocial because to maintain that benefit, you have to keep taking the medication, as opposed to here where you can get to an endpoint with the intervention. So it's not completely independently meeting age-appropriate expectations. It's meeting age-appropriate expectations while taking the medication. So that's the reason for that sequencing. And finally, we put accommodations last, although in a study we published a few years ago of IEPs across a dozen or so middle schools, they're by far the things used first and most often. And the problem is, or the reason that we put them last is because they never will achieve that goal. They will never get the child to the point of independently meeting age-appropriate expectations. How many years can you give someone extended time before they can start completing it in the time given? Forever. There's not even a premise that it's going to help them be more efficient, right? It's just lowering the bar. Most accommodations, giving students teachers notes, that doesn't teach them how to take notes. That just lowers the expectation, right? So this one we put last because it has no hope of achieving what we said was our primary objective of providing services, was to meet age-appropriate expectations independently. They're still on here though, because it doesn't mean that they're never useful. For example, well, for a lot of kids, they can be getting things from multiple layers at the same time. This is just a suggestion for how to prioritize them. But if there's note-taking interventions, for example, we did a study in the 90s looking at note-taking interventions for adolescents with ADHD. But it takes a few weeks for the student to be able to independently take notes in classes and do it effectively. During that transition time, it makes perfect sense to be giving the student either another student's notes or the teacher's notes, for example, until they learn to independently do it themselves. And then you would withdraw the accommodation of giving them the notes, and you would start focusing on the interventions. I often use a medical example to kind of point it out to show to me how compelling this sequencing is. If somebody has a back injury and they're no longer can walk, an accommodation is building ramps to the front doors, right? Because that's a differential boost. They help the person on a wheelchair far more than they help me. I can walk up the stairs or go the ramps. It doesn't really matter. So that's what differential boost means. But if it becomes available, an operation or a surgery that can allow that person to walk again, that's an intervention that would allow that person to meet age-appropriate expectations. How many would choose to keep the ramps? No, I'm not doing it. It costs more, I know, and it'll take work to do rehab, but let's just go with ramps. The choice seems so much more obvious sometimes when you talk about medical examples like that, yet in our schools, we're choosing ramps right and left for these kids all the time, even when there are interventions that are available. We're not doing them, and I think that's a major shift in how we need to do these things. In fact, that wasn't always the case. When I taught special education in the 80s, accommodations weren't what we did. remediation, behaviorally, academically, all of that was much more of a priority than accommodations are today. So, but there are some things that actually do provide the differential boost that's just part inherent in the accommodations definition. I already mentioned it's the most frequently used. And at the time when Dr. Harrison published her study, there was no evidence that any service met the criteria for accommodations for kids with emotional behavior problems. But there is now. One of my doctoral students was convinced that reading aloud may meet the definition of an accommodation for students with ADHD. Read aloud is clearly, I'm not familiar with the studies, but I can't believe it would fail that definition for kids with reading problems, right? If you read a test to a child who can't read very well himself, he's likely to do better on it. But if you read a test to a kid who reads fine, it's going to make much less of a difference, right? So that's differential boost. Clearly with kids with reading problems, that makes sense as an accommodation. But he thought it might for kids with ADHD. And his rationale was that it helps sustain attention to detail over time. It reduces errors due to lack of attention to detail and due to drifting. So he conducted a pilot study first in a summer camp we did with kids, some of which were diagnosed with ADHD and others who didn't. And he actually, all kids went to an American history course. These were middle school age kids. And then they took, after the course, after the class each day, they either took a quiz on the material in a read aloud condition or in a silent condition. And they didn't know till afterwards. And their results are exactly the definition of differential boost. In the silent reading condition, the kids with ADHD did much worse than the kids without ADHD. However, in the read aloud condition, the difference almost went away completely. And that was a pilot study, and for his dissertation, he said, I wonder what the impact of read aloud would be on the state standardized tests in Ohio. So he got an old copy, just 3 or so years old. You can get them from the State Department of Ed. And he randomly assigned kids with and without ADHD to either the silent or read aloud condition. And he found the same thing. That dashed line is the indicator of proficiency according to the state test. And you can see the kids with blue are ADHD, and in the silent condition, the mean is under that proficiency, and in the read aloud condition, the mean is over it. And there's no difference for kids really without ADHD. Again, the definition of differential boost. And if you look at it in terms of number of kids in the ADHD silent condition, only 4 out of 13 met that proficiency standard when they weren't having it read aloud. However, in the read aloud condition, it switches. 8 out of the 13 met the proficiency standard. So this made a difference in terms of performance on the standardized test for the kids with ADHD in terms of the read aloud condition. Notice again then, on the kids without ADHD, the 2 bar graphs look almost identical in terms of those who passed and those who didn't. So if you want to do an accommodation for testing with kids with ADHD, hopefully while you're also doing interventions, then read aloud seems one that's at least supported and meets the definition. So let me show you now where more of our work is related to interventions for adolescents with ADHD, and this is where I'm getting to the Challenging Horizons program. These are interventions that have any evidence in the literature and are clinic-based for teens with ADHD. There's a program called STAND that Maggie Sibley, who is one of my former graduate students now down in Florida, developed. It has a lot of the CHP-like components in it. Cash, Aaron Hogan and I developed this. It's similar to STAND. There's a group in Belgium called Saskia van der Oort and Bianca Boyer, who had a Plan My Life, which was an organization-focused intervention. Family therapy, Russ Barkley did studies in the 90s and 2001 most recently, looking at family therapy approach to adolescents with ADHD. And his conclusion after those 2 significant studies in his 2001 article is it's not worth doing family therapy with kids with adolescents with ADHD. didn't produce enough meaningful change. And the way I disagree with him to some extent, I think it's probably inadequate to only do family therapy with kids with adolescents with ADHD, which is what he was doing here. I think you need to have a lot of the school-based stuff going on in addition, or at least in order to have a difference. And then we did one of the first ADHD adolescent med studies, and there's lots of evidence showing that can make a difference. The summer treatment program, some of you may be familiar with that. Bill Pelham started it. It's in a variety of cities all over the country. There's an adolescent version that, again, Maggie Sibley's running now down in Florida. Then there's school-based interventions. There's the Challenging Horizons program, which I'm going to talk to you about, and then HOPS, which you may have seen. Josh Langberg published this through a couple NASP publications. And it's actually a subset of the Challenging Horizons program interventions that he put in a different setting. Josh also used to be one of my grad students, and he was a counselor in that program and pulled some of it out and made the HOPS program from that. There are also things we know are unlikely to be effective, like cognitive training, like CogMed. If you've seen the training they do, like continuous performance tasks they get kids to do over and over and try to get better at it. There's little to no evidence that it works. However, if you ever have an adolescent or child with ADHD who's referred to you because they're having problems under cognitive tasks they're being assigned to do on the computers, then CogMed can help that because they do get better at the cognitive tasks. They just don't get better in anything in life that matters. Cognitive therapy, we talked about that a little bit before. Family therapy alone, we mentioned. Social skills training, current models aren't helpful. Mindfulness meditation is a rave now, getting a lot of attention, unlikely to help adolescents with ADHD, but there is a couple interesting studies looking at mindfulness meditation for teens with ADHD who also have emotion dysregulation problems, and that's fairly common among adolescents with ADHD, and mindfulness may be helpful for kids with those problems. So Challenging Horizons program, I started in '99. I started as an after-school program. Kids come 2 days a week or 3 days a week when I first started for a couple hours a day, and we do the various kind of interventions listed there. I'm only going to show a couple of them to you. The organization ones, that's probably all we'll have time for. But kids with ADHD often get low grades in their classes because they don't turn in their work. And it's not just turning it in, it's knowing where it is even 5 minutes after they leave the classroom. They're incredibly disorganized and they're very poor at planning. So one of the first interventions we came up with when we started doing this in '99 and 2000 was systems, training interventions for systems to keep track of all their assignments, all their materials, and help them with planning. This is one of our basic forms that we use. This is the organization form. So the lists criteria down here about having your planner. Are there loose papers? And if you've ever done this, you know it's not just loose papers you can find. You can find underwear, you can find candy wrappers, you can find papers from 2 years ago that you can't figure out how got in this year's backpack reminder. So the first few times you go through and you do this, it takes a long time, and you have the kids fix it with you as you go. But then you do this over and over and over, 2 to 3 times a week until they develop a routine. And here's typical patterns of responding. There was a video I was going to show. There's a very small percentage of the kids where we actually had this kind of data. So this is percent of criteria on that organization sheet that they met. And by the way, those criteria, there's nothing golden about them. You can have really any organization system that makes sense, but you just keep it steady and you practice it. We came up with ones that tends to work in most middle schools, and we had others for high schools. This is weeks along the bottom. So note on these next 3 graphs, they go out to 18 weeks. So we're talking like 4 months worth of 2 to 3 times a week doing these interventions. Remarkably, there are a few kids, it's like, oh, well, no one ever told me, yeah, I can do this. And they start doing it and they have to do real well. This is a very small portion of the kids with which we do this. This is a common pattern of responding where a kid responds over the first month. He or she starts to gets up pretty good, and then it's like not novel anymore. They don't care, and they kind of drift off. But with persistence, you can get them back up to the level you want them to. And the most common of the 3 is this kind of slow and steady. And these are means within each week of the 2 or 3 times we met. So actually some of this data actually looks more like this. And what do many teachers and school mental health professionals and parents do the first time you have a downward dip? They say, see, it isn't working. Back to just extended time. You know, as soon as you get a downward trend, it doesn't mean it's not working. It's often part of a pattern, hopefully, that if you persist and do this with consistency and rigor, you can make a real difference. And I see my time is up. Here's a survival analysis we did with just the organization intervention. If you're familiar with survival analysis, you'll see there were 6 grading periods in this school, and we used our death criteria as their GPA was under 1.0. As you know, that's pretty bad. And at the beginning of the study, 100% of the kids hadn't died yet, right? They hadn't had that GPA because they didn't have a GPA. And then the dashed line is the control kids. The dark line is the kids receiving these organization interventions. And you can see by the end of the school year, 50% of the kids in the control condition had an overall GPA under 1. And about 85% of the kids in the treatment condition did not have a GPA under 1. So it makes a real impact on the grades they get to target the kind of thing, the organization stuff, that leads to these problems. Now you're going to have to just read really quickly because I don't have time to talk about these next few slides. But I wanted to show you, how you getting all this? I want to show you, we just completed a large trial. There's a paper that came out in Journal of Consulting and Clinical in January. We have one more. The cool thing about training interventions, too, is that gains that persist over time. So this is another study of grade point, using grade point as the outcome. It's over 300 kids, middle school kids with ADHD. You can see their GPAs prior to starting are all in the 2.1, 2.3 range. Their first quarter grades in the year in which we provided the treatment are all pretty similar, around 2.3. Then the kids in the control and the mentoring group, and I'm not going to go into that one so much, do the typical ADHD thing. The beginning of the year grades are as good as they get, and they're hanging on for dear life the rest of the year. You can see even in the year afterwards, these kids have that same pattern. But what's interesting is the GPA for the kids in the treatment group continues to differentiate itself more and more from the kids in the control group. The greatest difference between grades is 1 year after treatment ended. Treatment ended here, and their GPAs continue to get better compared to kids who didn't get this. That's the goal of training interventions. You develop a skill set that becomes routine, and then you apply that independently, again, to meet age-appropriate expectations. That's an intent to treat analysis. If you just look at the kids who, I can just show it here, who were, we'll go to grades. If you just look at the kids who completed treatment and compare them to similar kids in the control group, the effect sizes are even bigger. Case means just the kids who completed. It's a type of analysis for that. You can see the effect size a year after treatment between those groups is about 1. What does that mean in terms of grades? So in the treatment year, the GPA remained about the same, about 2.3 for all kids. Control group started the same, but declined to a D GPA by the end of the year. So these are the kids who completed all CH, or 80% or more of the sessions. To me, the more remarkable thing is the effects of the following year. You had the treatment group again stay in the mid-C GPAs, but the control group started lower and ended again with a 1.4. Kids failing some classes of kids getting a GPA of 1.4. So that is after a year after treatment, the grade point average is still 1 letter grade difference is a good bit. So this is the last slide for today because we're out of time. What the problem is in an after-school program, although it provides you a lot of time to do these interventions and many others I didn't share with you, we had the greatest amount of attrition there because it's a pain to go to an after-school program. Parents have to pick them up or find alternative transportation. Middle school and high school kids don't like to stay after school. So it had a potency and benefit, but an attendance deficit. what we've done and piloted in a few schools is we've put CHP into the kids' daily curriculum. So many kids, at least in schools around where we are, and I know some other places as well, if they have ADHD or get an IEP or 504 plan, they'll have a small group study hall. And what they do in those small group studies halls, if you've ever seen them, is the teacher's assigned to it, and their job is to provide a pestering intervention. So they go around and say, get back to work. I told you have these math sheets to do, and when you're done, you tell me, because you're behind on 14 other things, and we got to get this caught up. We actually got a few schools to replace this pestering intervention with Challenging Horizons program, and we went and trained those teachers how to do it and provided it to those kids 50 minutes a day during these small group study halls, which is about the same dosage of time that we were doing the after-school program. And they show up. It's on their schedule. It's not inconveniencing their parents, and it's a much more efficient and integrated version of it. So that's the next step. We've done a little piloting. We're ramping up and doing bigger studies with that fully integrated version, but that's where we are in terms of trying to develop and evaluate school-based interventions for teens with ADHD and related problems. Thank you for your attention. Yes.
I just have two questions, not entirely related. One is in regard to transfer of the program that you were talking about, the CHP program. So with the folders, and you can get them to be super organized with folders, and that's great, but in their other activities, did they transfer any of the skills or heuristics that are in there, but not necessarily explicit? I couldn't read all the details, so I don't know how explicit those heuristics are for, well, what does it need to be on, what does one need to do in order to be organized in the kitchen, in the homework, right? There's lots of places where you can be disorganized. So one, does that transfer? And the second thing has to do with schools and teachers. So as someone who coordinates a program, I teach secondary science teachers. I know, unfortunately, next to nothing about these kinds of things. And as a school, we're trying to fix that, but it's not trivial. And my question is, how much is it expected that teachers know these kinds of things? Or is this really the study team or the folks in the school, the guidance counselor, whoever else in the school works with the children? How critical is it for a regular subject matter teacher to understand and what of this should they understand? Because they're not going to implement CHP in their classroom per se, but there might be things that they can do to help. So if the child's supposed to know that there's binders and rings and stuff, one could remind them to, by the way, instead of waiting till study hall to realize that something they could have done in class. Because ultimately, they should be fixing it in study hall. They should be fixing it the minute they get the piece of paper. Right? Yeah, that's ideal, and that's where we headed. You had a few different questions there. I'm just. For example, when our staff works with the after-school kids on those organization interventions, they would sometimes come and tell me, like, do I really give him credit? Because I know before he walks in the door, he's fixing all his binders and folders and things. And then he comes in and, it looks fine. And I say, yes, because that's the first step of generalization, right? One, they know the criteria and away from you, and they know they should have had it this way. So generalization isn't a dichotomy, go from none to all of a sudden they're doing it everywhere. So if they're thinking about it in the hall before they get here, that's a first step. And so getting teachers to prompt on some of the organization criteria would be very helpful. And when we piloted our integrated version, we actually were able to do that a little better than we did the after-school version. First, the people who are running it were teachers at the school, and they communicate better with each other than we could in the after-school program. So that was real nice. One of the other interventions we did in the after-school program that I've always thought could be done by content area instructors is the note-taking intervention. Because we taught the kids note-taking in the context of an American history class. And the teachers start by just doing, for us, it was, some of you may remember what this was the overhead projectors with the sheets and
but now you can write on boards or whatever. But anyway, they'd lecture for a couple minutes, then they'd stop and say, okay, I got to write notes. And they'd start with, all right, what was the main idea? What was I thinking about? Okay, this, and then they'd write it down. And they'd use Think Aloud, essentially, to come up with the notes. And you taper from that to the kids independently taking the notes. And during the course of that tapering, you're asking, anybody know what the main idea of that was? And then coming up and doing it that way. And in 2 weeks of doing that every day, the majority of the kids were competent in note-taking. And then, but the thing is, in middle school and high school, many kids don't need to take notes, right? They can look like they're hardly engaged at all and ace everything. It's just the way. So we came up with some things at the schools where we piloted this integrated one, where we would say, encourage teachers, like anybody who's getting a C or lower in your class, if they turn in notes and you give them performance feedback, you check them and give them feedback, they can get extra credit. And then you're not expecting it of the kids who don't need it, but clearly kids with ADHD do. In our study, it kept them more on task. They were not disrupting the class because it's incompatible with disruptive and off-task behavior, let alone they were doing better on their assignments and quizzes, because kids with ADHD are such passive learners, like they're hardly engaged, like proximity to a book should be good enough. And yet, if you can get them to listen to the degree that they can think, what's the main idea and what's a short way I can write it, and what's a detail, what you're doing is what most kids do naturally, like what's going to be on the test, what's important, and learn to write that down. Were there aspects of your question I didn't attend to?
So, no, I mean, you sort of said that it would be helpful for teachers to know some of this. I'm kind of hoping that some of this stuff gets taught in other courses, because I don't know. You just talked about, and but I think partly also is one needs to change instruction. I mean, my first reaction to note taking is like, I think, are they taking notes to begin with? They should be doing investigations and like other things inside, right? So I mean, on some level, the organization and stuff. Well, maybe they should. And then they wouldn't have to organize them. Nobody would, but
yeah. But across all academic courses, there is lecture and there is assignments and there are things, and that's what trips them up a lot. Yep.
Okay. Yeah. I was going to add on to that and say that I feel like it's the school district's professional development's job to offer workshops to teachers so they know how to infuse those kinds of things to teachers so they can use them in the classroom. I know in my school district we have AVID training. Teachers can take those, and that's kind of similar, teaching kids how to note take and organize their binders. So I feel like it's kind of the professional development committee job to make sure that teachers are aware.
But I would argue too, it's not just the workshops are one of the worst ways to get people to change their practices. What we really need is train the trainer models where somebody in the school is the expert and is going to support and coach and performance feedback the other people who are expected to do it. And there are other things. We have an intervention in CHP that targets social behavior and disruptive behavior as well, which is kind of got rid of, as I mentioned before, social skills training. It took a new model based on what is it about kids with ADHD in particular that's likely to lead to behavioral and social impairment. And so it looks very different, but I didn't have time for that part today. Yeah.
I have two questions. First, maybe I missed some information of your presentation. Like for the study with an experiment group and a control group, I was wondering why the control group, the students of the control group, decrease their grades.
Over the course of the year, kids, if you just look at kids, teens anyway, with ADHD, you could go pull report cards, I'll bet, from almost any school, and that's what happens to them. They get worse because everybody promises the year and they have it's a new year, fresh start, I'm going to work, I'm going to get better, and for the first few weeks they often do, and the report card grade is usually as high as it's ever going to get. But by this time of year, even by January, they're lost all concern about that. And
so at the beginning of their GPA, their grades was not the grades of their previous semester. It was the
yeah, within that. It's easiest to show here. So this was the year before.
Oh, okay.
The bars show you when the treatment year was.
I see.
4 grading periods within the treatment year.
Okay, the grading.
And this is the year after there was no intervention provided, the 4 grading points of the following year.
And I have another question. According to your presentation, there was a slide showing there are some interventions which are unlikely to be successful. So is that a meta-analysis, or because I see the first one is cognitive intervention, but I actually read a few articles showing like working memory intervention, executive intervention seem to be successful. I'm not an expert. I don't do research about that. I was just wondering.
Yeah, and part of it depends what you mean by cognitive intervention. So CogMed is commercially available cognitive training program, and they have studies where they conclude they're effective. But if you read it closely, their measures are performance on a computer task, like CogMed.
Right. So,
Who cares if they get better at that, unless that's the kid's presenting problem. I just can't do CogMed well. Well, let me help you. I mean, but it doesn't change anything in life. And cognitive training around, learning to stop and think before you act and things. Also, there's no literature supporting that, even though it was popular a couple decades ago. So, and if you look at executive training interventions, executive functioning training interventions, you need to be careful because that's part of its labeling. Like the brief, if some of you may be familiar with, it's a measure supposedly of executive functioning. But if you look at the items, they're school behavior. They're school functioning items. It asks, do they turn their work in? It asks if you do this. So they're not really looking at executive functioning from a rating scale. I mean, how could you measure that on a rating scale anyway? You can't. It's indices, it's behaviors that they presume manifest from poor executive functioning. And some people call organization training executive functioning training. But I didn't want to play that game because executive functioning is a hot term now. 10 years from now, it'll be something else. And that's just a label that's poorly defined and gets attached to things to make it sound better.
Thanks. I'm sorry, that's all the time we have for questions now, but I'm hoping that you might stick around for a little bit and have people ask questions directly. Thank you all very much for coming to our Brown Badges Week. Next week is going to be Kevin Clay, who's a student here.